All right, good morning. Today's class is Chapter 38, Patients with Special Needs. I'm going to cover different types of special needs that you need to be aware of, that you might come in contact with. And it's not just physical special needs, but there's going to be some other special needs here as well. So this is kind of the typical first few slides that are going through stuff. All right. So many people with chronic diseases and injuries have live at home or in other environments outside of the hospital. So we need to make sure that we're aware of these individuals and some of the special considerations that we need to take for these individuals. Patients with special needs include children born prematurely who have associated respiratory problems, infants and small children with congenital heart disease, patients with neurological diseases, patients with congenital or acquired diseases, patients with sensory deficits, geriatric patients with chronic diseases. And you may need to treat the children and adults who depend on mechanical ventilations, IV pumps, and other devices. So developmental disabilities, insufficient development in the brain, resulting in some level of dysfunction or impairment. So that's kind of their definition of this. It's an intellectual disability. Is an inability to learn and socially adapt at normal developmental rates. So you could have somebody who is, 20 years old, but they have the mental capacity of a 5-year-old. So the way you communicate with this individual and do your assessment is going to be challenging if you don't recognize that and you don't adapt to maybe asking questions that you would normally ask, say, a 5-year-old. So it can be caused by different types of factors. It can be genetic factors, like I said, congenital infections, complications at birth. This could be due to malnutrition by either by the mother during development of the baby, the fetus. It could be environmental factors, prenatal drug or alcohol use, which can cause a number of different things as that baby is being developed in the womb. And it could also be as a result of traumatic brain injury and poisoning. And that traumatic brain injury could also be as a result of, say, lack of oxygen when that baby is being born. So it could be at different time frames. May appear slow. The patient may appear slow to understand, may behave immaturely, so they may not be behaving like you would expect them to behave. Not have the ability to care for themselves, maybe not be able to communicate or understand or even respond to their surroundings appropriately. And they could have difficulty adjusting to change or a break in routine. So as soon as that their routine is disturbed, something that they're normally used to, could cause them to have a mental breakdown or even physical outbursts. So a complex autism is going to be the first disorder, kind of that special need that we would talk about. So autism spectrum disorder. It's a complex disorder that varies greatly in signs and symptoms. This is one where a lot of families truly believe that shots have something to do with this. Based on a study that was done back in England that ended up proving to be false. I have family on my wife's side that they truly believe this after their first son was born with autism. They had given, or he was not born, well, he was born with autism, but of course this does not develop, is not noticeable for 2, 3, maybe 4 years after birth. So after that child had received a bunch of immunizations that children normally would get, they finally diagnosed him with autism. My sister-in-law believed it was as a result of the shots based on the studies, even though that they were proven to be false. And her second child, they did no shots whatsoever. And 2-3 years into his development, he was diagnosed with autism as well. So it's kind of a proof that shots are not necessarily is not the reason that autism exists. It's going to be a genetic. Typically, it's a genetic thing. So it's characterized by impairment of social interaction, severe behavior problems, repetitive motor activities, verbal and nonverbal language impairments, and have medical needs similar to those of their peers without autism. So these could still have the same type of medical issues that you or I could have, and we need to be able to treat them accordingly. Now, the downside and the difficult part of autism is the communication aspect. There are several levels of autism: high functioning, moderate function, low function. So understanding their severity is important, and then utilizing the parents and family is going to be key with this, and learning how to communicate. A lot of the kids now are, well, I can't say a lot, but I do know of several kids now that are being taught how to communicate through an iPad or some other little tablet device, and it is a way for them to get out of their brain, basically, because the pathways are disrupted, so that they can still think and function in their brain a lot of times, but they have an issue with getting that communication out, which is what causes some of their outbursts. So as soon as they learn how to communicate, it changes the world, and it can make our job a lot easier as far as when we try to assess them to find out what's going on. They frequently have difficulty making eye-to-eye contact, and they resist encouragement to do so. You get into their bubble, and they could also have outbursts. They can get violent. They could sling poo. So you just don't know what you're going to get with autism. Down syndrome is a genetic chromosomal defect that occurs when 2 21st chromosomes fail to separate during fetal development. So this happens during development, and this is something that there are tests that can be done while that fetus is being developed to identify that defect. Increased maternal age and a family history are known risk factors. These with children or individuals with Down syndrome may confuse pronouns. They have facial extreme. Oh wait, nope. That was back on autism. Let's see. Yeah, here we go. So some of the physical abnormalities with Down syndrome. So they have more of a round head with a flat occiput, which is going to be that back section of the head. An enlarged protruding tongue. So when you think of airway, they already have a larger tongue, which could affect their airway issues. Slanted eyes, wide set eyes. So it's another physical characteristic that you can see typically without actually talking to this individual. Folded skin on either side of the nose, a small face and features, congenital heart defects. So a lot of times these children are born with a congenital heart defect. So that's the biggest concern for them, is that they're going to already have some type of cardiac issue when they're born. Thyroid problems can be common, and then hearing and vision problems are also common. So people usually do not have all of these signs, but a diagnosis can be made rapidly at birth because the signs can be seen. So again, when this baby is born, we can actually pretty much guess that this baby has Down syndrome by the physical features that we see. They are at risk for different medical complications. Again, approximately 50% of the children have congenital heart defects, may have instability of cervical spine, a BVM can be challenging to utilize, In the case of airway obstruction, that jaw thrust maneuver may clear the airway, and they may have epilepsy as well, and most seizures are going to be the tonic-clonic type with this patient. All right. So again, the picture here, and I'm sure most of us have come in contact with a child or an adult who has Down syndrome. They can lead actually somewhat normal lives. We see them as actors or actresses on TV as well. They've had TV shows that feature individuals with Down syndrome, so they can live a quite normal life as well. Patient interaction. You want to treat your patients as you would any other patient. Obviously, keeping in mind that what you say to this patient or how you communicate is going to vary. So how you normally communicate may be how you normally communicate with a child, even though this individual may be an adult. So you need to understand how to communicate with this individual. Have your team members wait until you can establish a rapport with the patient, because again, if you get in their bubble, if they get oversensitized really fast, and they can have those outbursts, which are going to make your job a lot more difficult. So coming up to your patient who has, say, autism or Down syndrome, when we go up to our patients normally, we kind of get up and we kind of get close to them as we introduce ourselves. We take a knee maybe, or squat down, get to their level. And with this patient, we want to kind of ease in slowly. We don't want to just rush in, because they're going to get overstimulated, and it can make our assessment that much more difficult. So we want to kind of warm up to the patient, keep others back, like it says. Soothe patients' anxiety and discomfort as you work through your assessment and treatment plan. So you want to reassure them, talk softly, explain what you're doing as you're doing it. Don't surprise them with anything. Again, they will get overstimulated and anxiety will go through the roof. And sometimes, especially with autism, these patients can become violent. And it is not their fault. Okay, it is just because of that overstimulation in the brain, and they have no other way of getting that anxiety out. Brain injury. Obtain a complete medical history from the patient, family, and friends, because you need to get a little bit from everybody that you can. An individual with a brain injury may not be able to think clearly. Their thought process may be a little jumbled. Their communication may be jumbled. They might be thinking of a sentence as they're trying to communicate that like you and I would normally, but the words don't come out right. So getting some of that information from the family and friends will be important. Talk calmly, a soothed tone, watch for signs of anxiety or aggression. Again, and I can speak to this from experience. Overstimulation with somebody with a brain injury is kind of detrimental to that person's anxiety. So you get into their bubble, you overstimulate them with a lot of talking, talking really fast and asking a bunch of questions like a machine gun. It overstimulates, and the anxiety starts coming out, and as the anxiety starts building, aggression can happen. So don't expect the patient to walk to the ambulance or stretcher. You want to treat that patient with respect. And again, brain injury is going to kind of show itself in different facets. This patient could have headache. This patient could have some type of, so they're not really wanting to communicate because of the pain. They may not be wanting to necessarily make eye contact. The verbal responses may be a little off, or they are unable to speak in full and complete sentences. It can present a lot of times like an individual with a stroke. They could have that severe anxiety and those outbursts because of the overstimulation of what is going on. Too many noises. You know, a lot of people talking at once can be overstimulating to these individuals because, again, I speak from experience. All these conversations in a loud room is completely overstimulating. And it's just hard to explain. It really sets this person's anxiety up to a higher level, and it can shut them down to where you're not going to be able to communicate or find what's going on. Sensory disabilities. So we could come across a lot of individuals, or we could come across, not necessarily a lot, but we could come across individuals who have a visual impairment. This could be caused by congenital defect, disease, injury, infection, degenerative disease of the eyeball or the optic nerve. May range from a partial to a total blindness. So you could have somebody who has a partial blindness, whether in one eye or both eyes, that you're going to have to understand how to communicate with this individual. So a person with a partial, they could be considered legally blind but still have some vision. So individuals with, so these individuals could have obviously a seeing eye dog. So you need to understand that you have to take the dog into consideration when you're going to be possibly transporting this patient. Do you take the dog or do you not? Do you call animal control? If you take the dog, do you let the hospital know, by the way, in my patch, we also have a seeing eye dog with us, so they don't get startled as you're walking this dog into the ER, which is not something normal. With this individual, you want to make sure that you introduce yourself when you enter the room. Identify yourself, because again, even if they have a partial visual disturbance or disability, they may not totally recognize you. So if you have somebody who is blind, this is like walking up to somebody and just startling them. You know, if you're playing around and you go and sneak up behind somebody and touch them, they're going to be startled. This is not what we want to do to these patients. We want to make sure that we let them know what we're doing. If and when we do vital signs, we want to make sure that we communicate when we're doing those vital signs. Hey, I'm going to be grabbing your right arm to do a blood pressure. So you're going to feel the blood pressure cuff tighten up. So you really have to explain your actions so that you don't get this patient all amped up. Unless it is a critical situation, the service animal can remain with the patient. An ambulatory patient may be led by a light touch on the arm or elbow, or the patient may rest his or her hand on your shoulder. So understand what's best for that patient. If they're ambulatory, you want to make sure that you guide them in the fashion that they are used to. A lot of times that they will tell you, hey, let me just grab your arm and just guide me. So you're going to allow them to grab, say, your elbow and kind of just guide them to a gurney or wherever you're going to guide them to. Gently guide them, but never pull or push. And then communicate, obviously, any obstacles well in advance as they're coming up. And we're pretty good about this when we communicate that with each other when we're, say, coming down stairs, coming down ladders. Same type of idea you want to utilize for these type of patients. Hearing impairments may range from slight hearing loss to total deafness. This is something obviously we deal with on somewhat of a regular basis with the elderly homes and some of the different care homes. We have the elderly who have some type of a hearing loss. Most common forms of hearing loss are sensory neural deafness or the conductive hearing loss. Clues: a person could have a hearing impairment, presence of hearing aids, poor pronunciation of words. So especially with somebody who was possibly born deaf, they may have learned how to communicate, but the pronunciation of those words are going to be a little bit different, and it's going to sound a little weird. Failure to respond to your presence or questions. So again, as somebody that doesn't understand, they're not hearing, they may not respond to your presence. So most common forms, so with that sensory neural deafness, they're gonna have, as a result of nerve damage, is the most common form, may be caused by a lesion or damage of the inner ear. Elderly persons will have some degree of sensory neural hearing loss. The conductive hearing loss is faulty transmission of sound waves, can occur with an accumulation of wax within the ear canal or a perforated eardrum. Clues, we got that, the clues. And one of the other, obviously, one of the other ways you might cue into somebody who has some type of a hearing loss is they could have that cochlear ear implant as well. So they could have a device that is mounted behind their ear with a wire. So it's another kind of dead giveaway that somebody has some type of a hearing impairment. Obviously, communicating with this individual, you want to face the patient while communicating. A lot of these patients especially those that have had hearing loss or hearing deficits all of their lives, may have learned how to read lips. So try to face them. Do not exaggerate your lip movements or look away. But you just want to try to talk normal so that they can understand by reading your lips what you're saying. That, especially if they even have some hearing, even a slight amount of hearing, being able to have those slight tones that they do recognize, and then visually seeing your mouth move can actually help them understand what you're saying. You never want to shout. American Sign Language is kind of a big thing. That's the nationally recognized language on using hands to communicate. If indoors, just adjust the lighting so patients can see you. So we want to try to increase those lights. And then try reverse stethoscope technique. So you can give them the stethoscope and speak into the stethoscope. Is kind of what it's talking about. So some of the basic signs they show here, obviously sick is touching your forehead, touching your stomach. Hurt is actually touching your fingers together. This is the sign for hurt. Help, so you put your hand on top of your palm and raise up is help. Other ones are going to be thank you. So fingers to the kind of the lower lip, chin, and bring those out is thank you. Please is a good one to understand. It's open. It's a hand, open hand, rubbing across the heart. Sorry is a closed fist. Again, rubbing across the heart. Where, so it's a finger pointed up, and if you do where hurt or where sick, is going to help cue in like a question. So there you go. Now you have a question of how to communicate. So, and then also there's a sign for like ID or driver's license is going to be this is kind of the sign for driver's license. So that's going to help you understand, obviously, if you can get their driver's license. So where's your ID will help you obviously find out their name. Just because they don't know how to verbally communicate, or their inability to verbally communicate or hear, that don't forget the other tools that you have. You have a tablet that you can utilize. Get a pen and paper and handwrite your questions and let them respond with handwriting as well. Those will all help. There are some other helpful sign language terms that you could learn. Obviously, this is more important if you have, say, a regular who knows sign language, or if you have a community within your city that obviously that is deaf and utilizes ASL. So hearing aids cannot restore hearing to normal. They can only improve hearing and the person's ability to hear. or listen. So there's several types. Again, they have the behind the ear, conventional body type, in the canal, completely in the canal, in the ear. And so we've seen, I'm sure you've seen a lot of the different ones. Like there's super tiny little earbuds that go into the canal, the ones that wrap up and over the ear, and again that cochlear implant as well. Have the patient insert their hearing aids. Never try cleaning the hearing aids. If hearing aid is inserted correctly but not working, troubleshoot the problem. So with troubleshooting, you want to make sure that it is turned on. It has, maybe try a fresh battery if it's not working. A lot of times these individuals will have spare a cache of spare batteries that you can utilize. Check the tubing to ensure that it is not twisted or bent. Make sure that the switch is set on M, which is microphone. For conventional hearing aids, try a spare cord. And check ear mold to make sure it is not plugged with wax. So here's a picture of a bunch of those. Some of the most common ones that I think we see are going to be like most of those, except for the one in that conventional body. I'm not too familiar with that one. But the rest of these are pretty common. That completely in the canal is actually going to be difficult to see, and you may only see this little. This little giveaway is going to be almost looks like a water drop hanging on the edge of their ear. We'll kind of give that one away if you don't absolutely see it deep in the canal. Any questions so far about sensory disabilities, sign language? Again, I can't stress this one enough. If you have an individual that you deal with on a regular basis, please learn how to do sign. Just some of the basic questions, and then make sure you have a pad of paper readily available with a pen. And then you can utilize the tablet on the assessment tab and switch it over to the body. So you can switch it to body to actually have them show you, click on what part of the body is actually hurting, as you're assessing. Okay, CP, or cerebral palsy. Cerebral palsy is characterized by a poorly controlled body movement. So a lot of times these individuals are going to be in a wheelchair, or they could have a form of crutch that is binding, that they can kind of wrap or rest their forearms in for assistance with walking. Possible causes are going to be some developmental brain defects in utero, traumatic brain injury, and that's going to be just after birth, infection during a neonatal period or infancy, or it can be a genetic cause. Some of the symptoms and associated conditions are spastic movements of the limb, so they're going to have very poor control of their limbs, inability to maintain proper posture. They're going to have some visual and hearing impairments, and they potentially could have epilepsy as well, along with some intellectual disability. So they may not be able to communicate as effectively as a same person their age normally would. They will have some various levels of mobility. So again, they could walk with assisting devices, or they may be stuck in a wheelchair, and a lot of times that's going to be some type of a motorized wheelchair. Grimacing and uncontrolled movement may make speaking difficult and speech hard to understand. May use computerized household controls, speaking aids, and motorized wheelchairs. Some of these devices are going to be like a light or a laser that they put on their head like a halo, and they point it at a screen, and that pointer will help select pre-programmed words or the letters on a keyboard in order to help them form a sentence to communicate to you. So it can be very challenging, and the biggest thing with this is you need to be very patient as they try to get that communication out. Assessing the ABCDEs is most important. Observe the airway closely. Sometimes with these individuals, they may have excess saliva as well. They could have, due to an increased production of secretions and dysphagia, may require aggressive suctioning to clear that airway. A lot of times these individuals will have some type of a caregiver with them, and asking that caregiver, utilizing that caregiver as a reference to find out what's the easiest way to do different things, communicate or whatever, what their patient's norm is. The other thing with this is, now if this is your patient and you're out and about, if they have a power chair, those are relatively heavy. How are you going to get that? How are you going to take care of that? So usually a caregiver should be with them, that they could transport that as well. But if not, sometimes these individuals are pretty independent. They can be very independent. So they might be out and about, and now you have to figure out how to manage that power chair. So something to think about. Some important considerations is, do not assume that the patients with CP have an intellectual disability. Just because they have a difficult time communicating doesn't mean that they're intellectually disabled. They could be they could be smarter than you and I. They just have a hard time getting those words out. Patients have an unsteady gait and are prone to falls. They take walkers or wheelchairs along during your transport. Approximately 25% of the patients with CP also have epilepsy as well. With this patient, let's see. So if the patient has a specially made pillow or chair, the patient may prefer to use it during transport. So we need to take that into consideration, because our gurneys are built for speed, not for comfort. So you want to pad the patient to ensure his or her comfort. Never force a patient's extremities into any specific position. So they might have some musculoskeletal deformities that kind of are going along with part of their disabilities as well. Cystic fibrosis, characterized by an increased production of mucus in the lungs and digestive system, caused by a defective recessive gene inherent from each parent. Diagnosed in infants and in young children. They're prone to development of venous thrombus. It could also have that pulmonary manifestations of pneumonia, pneumothorax. They could have a nasty cough, respiratory distress, or even respiratory failure. Malnutrition and poor growth rate are common with cystic fibrosis. They receive frequent or continuous treatment with antibiotics. Medical devices promoting lung function and removal of mucus may also be used. Maintaining airway, providing oxygen and suction is needed. And humidified oxygen may help thin mucus and improve respirations, which we don't really get that opportunity to transport with humidified air, but it's something to think about. If they have one of those little device with humidified air that we can hook up to our oxygen, maybe consider taking that with us. Multiple sclerosis, or MS, severe, incurable, degenerative disorder involving the central nervous system. Some of the sources describe a connection between genetic predisposition, environmental factors, and possibly nutritional or exposure to a particular virus. Strikes women in their 20s to 40s 2 to 3 times more often than men. So this could be something that is even misdiagnosed in men and women in their 20s to 40s. Patients report periods of varied improvement followed by a relapse and progression of disease. A vast array of signs and symptoms related to neurologic functions are possible. They can have skin breakdowns, may result from the immobility or poor positioning as well. Their life expectancy may be normal, but symptoms may cause significant disability or impairment. With these individuals as well, you're going to have, you need to take into consideration the psychological support. Because somebody who has been diagnosed with multiple sclerosis, they're going to have, or they could be experiencing a lot of depression, anxiety. You know, some people don't believe that some of the symptoms that they exhibit are real. So they have that emotional aspect that people don't believe, even though they have been diagnosed. So some of the things that you might see with this individual may appear to, I don't know, they could appear to be fake, but this person is truly having a medical issue as a result of multiple sclerosis. So again, we need to be patient with these people. We need to be considerate, and then use some good ABDCE assessments, and then provide them some supportive care, including psychological support. Manage with medications. This MS is managed with medications, physical therapy, and counseling. Allow additional time to assess due to cognitive or communication barriers. And again, that supportive measures, IV hydration, analgesics, muscle relaxing medications, which we don't really carry muscle relaxing medications. But if that patient has some, maybe help them take it if need be, as prescribed. Careful patient positioning and assist ventilation when needed. Let's see, there was one. Yeah. All right. Muscular dystrophy causes slow and progressive degeneration of muscle fibers. So this patient is going to progressively get worse as time passes because the muscles start breaking down. So severe manifestations of certain specific diseases, cardiomyopathy, congenital impairments, and respiratory compromise. So I guess the book talks about Duchenne muscular dystrophy, that's DMD, is the most common type that chiefly affects males. And treatments are limited to careful positioning, supportive treatments, and then assistive ventilations, as they might have that respiratory compromise. Spina bifida, I talked about this a little bit when we did I think when I did OB and neonate. So it's a birth defect caused by incomplete closure of the spinal column. The picture here kind of shows what you might expect to see, a version of what you might see with a spina bifida patient once they are delivered. The opening can be closed surgically, but the child is often left with a spinal and neurological damage. Latex allergy with this individual is going to be common. So somebody with spina bifida is typically going to have a latex allergy. This patient is going to be typically confined to a wheelchair. They're going to have some other types of neurodeficits, especially into their lower extremities. They could have a defect into their core as well, with some of their organs. They may have feeding tubes, other like Foley catheters, things like that. A lot of times these patients are going to even be wearing some type of a diaper because they're compromised neurologically in the lower extremities. They could have partial or even full paralysis in the lower extremities. And again, like I said, or loss of bowel or bladder control. So not only some type of a Foley, but this patient may also have a colostomy as well. And some of these patients actually can be fixed prior to birth. They can actually be fixed while they're still in in the womb. It's kind of crazy. But again, just because they go and fix some of that problem, that patient will still have some type of a deficit once they're born. Paralysis caused by stroke, trauma, birth defects. Several types of paralysis. You're going to have the hemiplegia, which is the paralysis of one side of the body. So part of the hemisphere. Hemi. Does that thing got a hemi? Paraplegia, paralysis of lower part of the body. Quadriplegia, paralysis of all four extremities and the trunk. So I think we see some of these obviously coming from life care, NIAC, facilities like that where they might have that paraplegia or quadriplegia for some of our nets. They go for special procedures. With these, patients are going to possibly have some skin breakdowns because they're kind of confined to bed or confined to a wheelchair. So we need to take that into consideration when moving these patients. Hemiplegia, so we see a lot of times with our stroke victims, where it's that they have paralysis to one side. When you examine these or assess these patients, they're going to have that possible flaccid one side of the body. Again, this could be as a result of some type of a trauma. So, spinal injuries, or even as a result of a traumatic brain injury. A person with traumatic brain injury can present, depending on where that damage is, can also present with that hemiplegia. Patients with dysphagia may easily choke and aspirate food and drink. So somebody with some of that paralysis, that quadriplegia, could also have other issues where they have difficulty swallowing. So they may be more prone to that aspiration. Paralysis of the respiratory muscles causes patients to be completely dependent on mechanical ventilators and similar devices. So we might have to, especially if we have a regular, learn a little bit more about those devices so that we can manage that patient a little bit better. A lot of times these patients have family, friends, caregivers, or even themselves that can help us understand how to use the pumps, these ventilators, so we can use them as a resource. These patients, again, like I said, they possibly could have decubitus ulcers, and they're decubitus ulcers are a constant threat. External devices such as halo vests are used to immobilize the spine, as you kind of see in this picture here. So this patient could present a little bit more of a challenge in moving them. A risk for a life-threatening condition known as autonomic dysreflexia is a stressor within the body triggers a large release of catecholamines from the autonomic nervous system. So this is something that also you might come in contact or come across. So these patients are susceptible to environmental extremes and does not always entail a loss of sensation. Just because they can't move something doesn't mean that they've lost the sensation. So for a patient with priapism, maintain privacy and continue to provide supportive care. Scheduled urinary catheterization is required for many of these patients, and use a gentle touch when lifting or moving these patients. Again, these patients may have issues with some of the sensories in their extremities, but also that decubitus ulcer. If they're more prone to the decubitus ulcer, that's going to be very painful, and so sliding them could worsen that decubitus ulcer as well. So just be very cautious as you move these patients. Provide IV access and medication on the non-affected side whenever possible. So if you have this patient who has got hemiplegia, you're going to want to try to do, if it's right-sided, say they can't use their right side, you're going to want to at least try to get the IVs in that left side. But you still have the right side if absolutely necessary, but typically you want to try to use the opposite side, the good side, first. All right, bariatric patients. Obesity is a person with an excessive amount of body fat. So there's your terminology. So bariatric patients are a special consideration for us. Clinical concerns of the patient with obesity: airway procedures are made much more difficult. They have a lot more adipose, and it can be a little bit more challenging securing that airway. Bag mask ventilation may be ineffective, so you need to maybe consider your positioning of this patient. If this patient is laying supine, they may have a lot of adipose that is preventing you from actually increasing those, putting air into those lungs. So if you're trying to bag them and you're really getting poor compliance, try putting them up at an angle, maybe increasing that the head and elevate it, say 30 degrees, semi-Fowler, and you will probably get an increase in compliance with that BVM. Peripheral access is often problematic. If you haven't already experienced that in some of your clinicals, those veins could be a little bit deeper. They may appear closer to the surface than they actually are, or they may have poor vasculature, so you may not be able to find a vein in some of the normal spots that we typically go in. So like the ACs, the forearms, the hands, the wrists. Some of these patients you might have to access. Sometimes they have good vasculature coming across the top of the shoulder over into the chest. Look at feet. And obviously in some of those more critical patients, you need to consider utilizing the IO. Another issue is it could be very difficult to determine the extent of an injury in some of these patients. You may not be able to necessarily identify swelling because of all of the adipose tissue. So you need to do a good job, the best you can, at trying to assess this patient. Obese is used when someone is 30% or more over his or her ideal body weight. So the book talks about that. It might come up on a test question. I don't know. So obese is, again, it is used when someone is 30% or more over his or her ideal body weight. And it can often be attributed to low metabolic rates or even genetic predispositions. But ultimately, some of the bariatric patients, the causes are not fully understood. Some of your interactions with patients with obesity could be embarrassing for that patient, because even though they are obese, they may be embarrassed about their condition. So you want to try to provide them some level of comfort with talking to them, reassurance, that psychological effect. Many patients with severe obesity have a complex and extensive medical history. So these patients could have a plethora of medical complications. They could be a cardiac salad. They could have, of course, some of the other things that we consider and we typically come across would be like hypertension, diabetes. They have that higher predisposition for maybe stroke. So, and with the diabetes, they could have neuropathy, so painful lower extremities as well. So many have complex, yeah, we have that. If transport is necessary, you want to plan for extra help early with this patient. So especially if you already know the address is familiar. The typical ambulance and QRU may not be enough to extract this patient out to an ambulance. So you want to try to plan early on, especially if this patient ends up being critical. It's going to be that rapid transport or rapidly getting them out to the ambulance may be more challenging. You know, if we find these patients in a back room of a trailer, we have one that's on the west side of Post Falls. It is challenging getting her out of that bedroom down the narrow hallway when she's 500 pounds. It's challenging. We can't get people on both sides. So this individual, you're going to have to think of different ways of trying to get this patient out down that hallway, because ultimately our safety is most important. We need to protect ourselves as best that we can from things that we're prone to, like back injuries. Okay, so we need to protect ourselves, but at the same time, we need to think about different ways of getting that patient out while we protect ourselves. So utilizing maybe extra sheets, tarps, or even a Stokes basket. A Stokes basket is awesome because even though they may be overflowing the sides of it, it has some rigidity to it, and it typically can withstand that weight, and it is something that is going to slide across the ground smoothly, and it's also going to help protect some of their backside. Again, these patients who are bariatric, they've maybe, like this one that we had, she hadn't left her trailer in 4 years. 4 years. So I can only imagine the ulcers and the skin breakdown that she might have had on the backside. And as we are dragging her across the carpet, even on a tarp, that is going to place some friction on that backside and it's going to cause additional harm. So we need to think that we want to get these patients out without doing additional harm to them as well as us. So again, utilizing the different tools we have and making sure you have extra hands to provide safety for ourselves as well. Treat the patient with dignity and respect. They're a person, so we need to make sure that we treat them with dignity and respect. Avoid trying to lift the patient by only one limb. Their body cannot, more than likely, cannot handle that kind of weight and that kind of torsion. So coordinate and communicate all moves to all team members. So this is going to be very important, just like when we are dealing with a patient that is C-spine precautions, the person at the head dictates the movement, right? So the same consideration possibly should be done with this, with a bariatric patient, is one person needs to be in charge. One person needs to make sure that everybody is ready and that everybody knows the game plan. We know it, we're going to lift up, or are we just going to drag? Which direction are we going to be going out? So all that information needs to be communicated early and coordinated appropriately, again, to provide safety not only for us, but for that patient, because one person, especially in this type of situation, one person doesn't have the game plan, it's going to be that weak link and could ultimately drop that patient, which would be bad. Plan your egress routes to accommodate the patients, the equipment, and lifting crew members. And I haven't seen it in this area, but of course I've seen this kind of stuff on TV. You know, we might have to take out a wall at some point. That we will see that probably in our area, where we actually have to take out a wall in order to facilitate getting this patient moved out to an ambulance. And with that, is the ambulance going to be able to facilitate this patient? Or do we need to actually consider a different mode of transportation for this patient? We need to take all of this into consideration. Maybe getting this patient up into the back of an ambulance without the gurney is what's going to be necessary. So how are we going to facilitate that? And once we have that plan, how are you going to make them comfortable if they are unable to fit on the gurney in the floor of the ambulance, because we have that track system? I mean, there's so many different things to consider. And then how are you going to secure them? Probably not really going to be able to secure them. You're going to make a really slow transport. And then with this, you're going to need to make sure you notify the facility, Kootenai, early that you are bringing a patient in, give them an idea of what the weight is of this patient, so that maybe they can meet us outside with a Hoyer sling or whatever. We can try to make another game plan. So I mean, this is like chess. You need to think steps in advance with this patient of how to facilitate moving them. All right. Cool. Any questions on that last piece? Boom, bada boom. All right. So we're going to take a break, a short break, and then we'll be back to it and then finish this out. All right. So we'll try to finish this out. It's going a little bit longer than I expected, but it's only like 50 some slides. So we're almost done. So we got tracheostomy tubes. These are tubes that are used to facilitate breathing, placed in a stoma. Stoma is going to be that hole within the neck that goes into their airway. Laryngectomy is a surgical procedure in which the larynx is removed, and you do not introduce liquids into the stoma. Why? Because now you're aspirating the lungs, because that is a direct pathway directly into their lungs, which obviously would cause kind of a breathing difficulty, right? So we don't want to do that. It can be either temporary or permanent, depending on what the needs are for that patient. Patients with a laryngectomy cannot produce normal speech and must learn to swallow and regurgitate air from the stomach or use an assistive device. Patients with the tracheostomy tube are those who depend on home automatic ventilators and those who have chronic pulmonary conditions. Mechanical ventilators can be used for a lot of these patients. What am I doing? There we go. Oh yeah, let's go back. I'm sorry. So obstruction of the tube is life-threatening for these patients. Use the DOPE mnemonic for helping clear these airways and assessing these patients. Make sure you do a good job assessing the patency in the airway, and assess the flow of oxygen and ensure sufficient oxygen. Sometimes these patients are able to breathe normally on room air. Some have oxygen that is supplemental, that has a trach mask, obviously, that would go over that opening. So you want to make sure that obviously that they're getting good flow and understand how to suction the airway if you need to suction. In your book, apparently the suctioning and cleaning a tracheostomy tube is going to be on steps in the skill drill 38-1. It'd be a good one to learn. Mechanical ventilators, or patients may not have an underlying respiratory drive, so they may need the use of a mechanical ventilator to help get them the oxygen that they need. Assess the patient's chest for synchronous movement. So you're going to want to watch the patient's chest. Make sure that they have bilateral chest rise and fall like we would with any other airway assessment. Use a stethoscope, listen to lung sounds left and right, uppers and lowers. A tracheostomy collar is an oxygen delivery device for patients with tracheostomies. So you may come across something like that. Patients using home mechanical ventilators require assistance throughout transport. So here is going to be the kicker, right? So a lot of times we know that we have some type of ventilator and we need a CCT nurse, say from NIAC or Life Care or La Crosse, to transport these patients. It's nice when we have that information in advance. But we may not get that information when we respond to a home and they have one of these devices. Just like we go to a home and they're on some type of medication pump of receiving some type of medication, whether it's morphine or some other medication that they need. With these ventilators, we need to utilize that patient and or the family, friends, home health caregiver for support and understanding how to utilize this, because we will not have the opportunity to go get a CCT nurse a lot of times to transport this patient. Avoid adjusting home ventilator settings unless you are specifically credentialed. Obviously, if you're a CCT nurse, you understand some of the different settings. You may not understand each individual device. It may take a moment to figure it out. But again, as normal providers here that don't do CCT, that we're not CCT certified, we may need to utilize that patient's family or friends, again, or the healthcare giver to assist us in managing that ventilator, and maybe have them manage it on the way to the hospital. So maybe it's appropriate to bring them with us so they can manage it, because truly they're going to be the experts with that device, not us. If they can manage that, that's one less thing that we have to worry about while we take care of the patient with whatever else is going on. Apnea monitors used when an infant is born prematurely, designed to sound an alarm if the patient experiences bradycardia or apnea, so they stop breathing. Patients may be able to provide a computerized printout. So I have never experienced one of these personally, other than what we read about in the book. So with the prematurely infants that are born prematurely, it's for 2 weeks to 2 months after birth typically is what they're going to be utilizing this for. And it's attached with electrodes or even a belt wrapped around the chest or the stomach. So that's how it gets its connects to the computer to get that alarm. Internal cardiac pacemakers, I'm sure most of us have experience with this as far as with our patients. It's an implanted under the skin to regulate the heart rate, placed on non-dominant side of chest. So again, we typically see these on the left side of the chest, but again, it's supposed to be the non-dominant. So idea is you can still find these on the right side of the chest. I have seen scars on the left where they said, oh yeah, they have a pacemaker, and we look and there's a scar on the left but no pacemaker, and then you look over to the right and there it is. Pacemakers implanted underneath the skin. May include an automated implanted cardiovert or defibrillator. So this could be that dual device that defibrillates and or cardioverts. So if that patient goes into, say, SVT, it can cardiovert that patient. That patient's going to know, and they're going to be able to let you know when that has happened. Never place the defibrillator pads or pacing patches directly over these devices. So with those patients that have those defibrillators up on the right-hand side, maybe just flip up the side for the pads. So you're going to do upper left and lower right of the chest, or do anterior and posterior, maybe more appropriate for placing pads on these patients. Yep. So left ventricular assist devices. This is a scary one because these patients are very special. Takes over the function of one or both heart ventricles. Patients should have a go bag, so they're going to have a bag set up for in case they have an emergency. Risk factors associated with LVADs include excessive bleeding. And the LVAD may be functioning in absence of a palpable pulse. So these are the patients where you go up to, they're talking to you, and you go up and feel a pulse, and they ain't got no pulse. And you try to get a blood pressure, they ain't got no blood pressure. What are you going to do? Freak out? Yes. A lot of times these patients have a phone number directly to their doctor or to the office that can help answer questions, or even what am I looking for here? The troubleshoot. maybe troubleshoot. Troubleshooting is going to be, I don't know, I'm going to need a change of shorts and drive this patient rapidly to the hospital. So which hospital are you going to drive this patient to, right? So probably going to be over to the heart. But again, this is going to be that point where maybe you need to contact that that doctor directly to find out what they would like. External defibrillator vest. So built-in monitoring electrodes and defibrillation pad. You want to avoid contact with the patient if the device warns that it is about to deliver a shock. It'll tell you, and you want to back away. If the patient is in cardiac arrest, the vest should remain in place during CPR. So it should continue to work. The idea is it should continue to work. You should be able to still do chest compressions, and then once it is ready to shock, it's going to tell you it's going to shock. That'll make sure everybody is clear so it can do its thing, and then you continue your chest compressions. That is a good one. I don't know. Other than we're going to place electrodes on the normal, try to get our electrodes in place. I've never experienced one of these. Shane? Have you? Josh? No, with the external defibrillator vest. I've never seen one.
So I don't know if they still live there. I know we had one in North Lakes for a while.
Yeah.
But I never, at that point in time, I wasn't ALS, so I don't remember how it worked with electrodes. But
so if you get one in your area, obviously if we get one in our area, we're getting those emails, which is nice. You know, when we get some of these like LVAD patients, other special needs patients, we're getting those emails. At least we are in Post Falls. Kind of giving us a heads up. Some of these patients are told by their doctors, hey, make sure you let the fire department know, local fire department know that who you are, what's going on, so that they can prepare. So we can do a better job of preparing to manage these patients so that should an emergency arise. I would assume that with this patient, we're just going to hook up our electrodes, our 4 lead as normal to identify the rhythm. And then from there,
I'm assuming they probably have where you can hook up our external stuff, like the puck we have, and they probably have something where you built it, you take it, add on, and so you can read the monitor, where that just acts like the pads, basically. But I wouldn't know for sure. I'd have to look at it.
So online, so Shane was saying that it's possible that some of these may have a device, the connection to hook up to our monitor's puck, as opposed to just having our normal pads. I think if all else fails, maybe, I don't know.
we had one.
Yeah?
We had one.
Well, how come you didn't speak up?
The guy had just got sent home and it shocked him, and that's why he called us.
Oh.
So, but it was like a big, like bulletproof vest looking thing, like it covered everything. And you weren't taking it off. Like you could put your 4 lead on. But other than that, we hadn't really encountered it, but it was a big bulky thing.
Tack vest.
Wires or anything that you could look like?
We didn't mess with a 12 lead or nothing. I don't remember the specifics, but I think we just 4 leaded, loaded him up because he was talking just scared as hell.
Right.
Because it woke him up, he was sleeping. But,
Huh.
yeah.
All right. Anybody else online got any input? Nope. All right. All right. So we have intra-aortic balloon pumps used in patients with cardiogenic shock. Decreases myocardial oxygen demand, reduces cardiac workload, and it improves the systemic circulation. It's difficult to move and secure in an ambulance with this patient. And that's about all I got to say about that.
Those are the patients that are usually not helicopters, but jet.
Oh, taken by.
Yeah, they're usually they're fixed wing, and they're usually by the specialist of the doctor, and his crew stays with that patient.
So the doctor and crews typically stay with the patient.
Yeah.
Goes by fixed wing during transport.
Yeah.
But so this is a patient with, if we're bringing him out to the airport. We might experience this taking them, right? Taking them out to the airport from the hospital.
Yeah, these are usually going to the cardiologist or the cardio. So it'd be like the Spokane Heart Institute there to like the Seattle Harborview.
We're saying we're going to find them at home. Right?
We're not going to find them at home usually. No.
Perfect.
Yeah.
And I do know with some of these, whether it's the LVADs or these, you have to be careful about giving them oxygen because it could change. It could mess with the device. So that was one thing I took away when we did have that patient in Hayden. You don't just put them on oxygen because it could be a negative.
So manage the patient, not the monitor. SpO2 sats.
Right, and get in because a lot of those devices will have a contact number and get in contact before you start any like interventions if you can help it because that's when putting them on a nasal cannula is not life-saving potentially.
Cool. All right. Central venous catheters located in chest, upper arm, or subclavicle area. So we experience this a lot of times, obviously, with our transports in and out of life care, lacrosse, NIAC. We're going to experience this. Increased risk for cardiovascular complications. You want to inspect and secure all external devices before moving this patient. A good thing to find out is to make sure that the nurse has made sure that the flows were still good. This is something that typically you're not going to be managing. We typically don't try to utilize these as a first unless it is absolutely imperative. And that's going to be typically, from what I understand, more of medics are going to utilize this should we need to push medications rapidly. But a lot of these patients, we still would try to get some type of an IV. The idea is with some of these central lines is that they're going to be getting, they need continuous access on a regular basis for something, whether it's medications or whatever. They need continuous access. So instead of having to stick this person with an IV, normal IV catheter on a regular basis, they hook up these lines. Also, these lines are going to be in place for patients for a short-term basis that could be a very difficult stick, somebody who has very poor vasculature. You still want to inspect and secure all external devices, like it says. Look for any signs of infection with these, and that would be something good to note. Gastrostomy tubes, referred to as a gastric tube or a GI tube, surgically placed through the abdominal wall, and it may still be, this patient may still be in risk for aspiration. You want to give this patient supplemental oxygen as necessary for any difficulty breathing. These tubes, especially if it's relatively new, it's going to be very painful. It could be very painful sight. So you also want to visually assess this location and ensure that there's no signs of infection. You're looking for that increased reddening around there, which would be indication of some infection. And the tubes that are coming out, you want to manage as well. Make sure that they remain clean and don't get mixed up with anything that could potentially cause that tube to get pulled out. Unless the gastric tube is dysfunctional, dislodged, or even partially dislodged, you want to continue tube feeding and transport the pump with you if this patient is in the process of being fed. I mean, this is the patient's food source, okay? So transport those as necessary. A lot of times when we see these obviously coming out of like these PEG and GI tubes and G tubes coming out of like these care facilities, they disconnect the feeding source. So the fluids, they usually disconnect those for transport because it's not necessary. But like I said, so sometimes at some point you might need to transport while they're being fed. Shunts, it's a big one. For patients with chronic neurologic conditions, they could have ventriculoperitoneal shunt drains, which access fluid into the peritoneum. So it's going to be basically draining off fluids from the head down into the peritoneum. The ventriculoatrium shunt drains excess fluid into the right atrium. That'd be part of the heart. So the big concerns with these are going to be those blocked or infected shunts. It's going to change the mental status of that patient, so they could obviously have maybe a severe headache. They could have an increased blood pressure. They could have irregular respirations, which, what is that condition called? With head injury, irregular respirations. Change, yeah. Okay, so look out for that. Keep pressure in this. It keeps pressure from in the skull from building up. That's what these shunts are designed for. A lot of times it's for the hydrocephalus patients to drain off the cerebrospinal fluid. Fluid reservoir may feel during patient assessment or beneath the skin on the side of the head or behind the ear. So a lot of these shunts, you're actually going to be able to feel them, especially, I mean, you're going to see them if they have short hair. There's going to be this like tubular section that's coming off the side of the head behind the ear down into the neck. Big thing with this is, again, we don't want to put pressure on those. Let's see, what else? So infections are kind of a big deal within the first 2 months after insertion. So something to think about if they all of a sudden have a raging infection, they have a high temperature, no other significant like flu-like symptoms, but they may have an altered mental status. And it could be as a result of the increased pressure, which also may continue to increase because of a blockage or from that infection. Signs of distress, you're going to have that bulging fontanelles when it's in infants. So the fontanelle is that section on top of the head, could be bulging, which is an indication of increased cerebral pressure. You're going to have headache or projectile vomiting, which is something like you would expect in a traumatic brain injury. Altered mental status, irritability, high-pitched cry. I mean, this is, they're in agonizing pain when it comes to this. Fever, nausea, that's going to be also when it's kind of related to the infection. Difficulty with coordination and walking because things are going to be off. They're going to have so much pressure, it's going to affect how that brain is functioning, which could cause them to have that difficulty with coordination. They could have blurry vision, seizures, redness along the shunt track. So it could be as a sign of infection as well. And they could also have bradycardia or heart arrhythmias. Care includes with this patient airway management and artificial ventilation should you have some type of breathing issue with this. Vagus nerve stimulators is a treatment used by for seizures, not controlled with anti-epileptic medications. So sometimes medications don't necessarily work for seizure patients. They may have a vagus nerve stimulator. Used with medications to reduce frequency of seizures though, and it's not meant to replace the medications and not currently used in children under 12 years old. So you're going to experience this more into the teens and to the adults. It's surgically implanted under the skin, so you may not see, you're not going to see this, and can last up for 6 years or until the battery runs out. Colostomies, ileostomies, and urostomies. These are going to be the devices that are surgically applied to the abdominal area to allow patients to excrete their bowel and also the urine. So colostomy is a surgical opening between the colon and the surface of the body. So you're going to find that on the left side of the abdomen. Ileostomy is going to be that surgical opening between the ilium and the surface of the body. So where's the ilium? Which side? Right side, maybe? Anybody online? Huh? Ilium? Where's the ilium? All right, you get back to me. Look it up. You're online. You want to assess for signs and symptoms of dehydration with these patients. If patient reports diarrhea or vomiting, patient and caregivers must be diligent with daily hygiene. So then the urostomy is going to be that surgical device that allows emptying of the bladder into a bag. So it's a little different than the suprapubic catheter. This is going to be kind of that surgical, permanent surgical device that allows that. Basically, it's going to give them an external bladder. We actually have one locally. It's my first time experiencing that one. They said it was a urostomy, and I hadn't experienced that one yet. So these patients may need help with their devices. So again, with these patients, you want to give them some level of dignity because they're potentially going to be embarrassed about it. Obviously, the smells with these are going to be quite obtrusive. The one that we had, it was a urostomy. It was recently implanted. Basically is a hole, and she needed a new, she kept having a leak of the bag, so around the seal. And again, I never experienced this before. Me and my partner end up looking at the directions, because it comes with directions on how to put the new bag on and the new seal. And we end up helping them put this new bag on. This is something that you should totally be able to do. This is not necessarily ambulance transport. But worst case scenario, maybe it is take them to the hospital, have somebody that is more experienced get this squared away, and then maybe you might have to hang out for a minute, learn something, and then take this patient home. So there's that. All right. With these patients, the big thing for them is that they're going to have to maintain a high level of diligence when it comes to their health care and their hygiene in order to keep this thing clean, relatively clean on the outside to prevent further infection. All right. Patient assessment guidelines. Assess the patient's baseline. Nothing changes here. Do a good sample. Use short, simple questions, simple words. And reverting back to the beginning of this chapter, your questions may have to be specially catered to that individual's mentality and their level of understanding or their level of receiving questions, whether it's by verbal or by written or even maybe some sign language. Home health care. Patients may be infants, elderly, have chronic illnesses, or the developmental disabilities, which we may come in contact with any of these types of patients within a home. May be called because home care provider found the patient injured or recognized a change in the patient's status. They say they saw something that they don't normally see, and they called us for assistance. So we need to take that into consideration. Okay, a lot of times these patients have that home health care giver that knows them relatively well. It's going to be a little bit different going to a home and dealing with a home health care provider than it is going to, say, Life Care, and we walk in and they're like, well, I don't know, this patient's new to me and I just got on shift. It's not going to be that same interaction. We're going to get to a home and this person is going to know the ins and outs of this patient typically. It's going to be rare that we're going to get there and the patient, the caregiver doesn't know much. But we also may be called because they have an issue with a device that they need help with. So we need to be up on some of these different devices and how to troubleshoot. Let's see. All right. So terminally ill patients. This is a challenging area because we have to take a bunch of things into consideration with this as well. So terminally ill patients may receive hospice care at a hospice facility, or they may actually receive that care within their home. And it depends on a number of factors where this person is. Sometimes we have these patients who are terminally ill. They don't want to go to a facility. They're not ready mentally. They would rather spend the rest of their days in an environment that they're familiar with. So patients with illnesses such as cancer, heart failure, end-stage Alzheimer's disease, acquired immunodeficiency syndrome are going to be some of the typical patients that you might see with this. Usually need only supportive care. Sometimes with these patients, it might be just going in there, doing an assessment, seeing where things are at, and then, you know, sometimes we get that phone call from family, or maybe it's a neighbor that's concerned, and we have to go in there and actually do an assessment. Don't forget to do an assessment. But then when you understand that this patient is with hospice care, that we need to do a good job in communicating with hospice if they're not on scene, and find out what they would like us to do. A lot of times these hospice care patients, when they're at their own private residence, if hospice wasn't notified, it is up to us to contact them so that hospice can come and take care of the patient. We may need to manage that patient a little bit till they get there, but it is up to us to sometimes to make that phone call. It's not a matter of just whisking him off to the hospital, because in a lot of cases, taking these patients into a hospital changes their hospice status, and it can actually kick them out of hospice, and then they have to go through the rigmarole of paperwork and other assessments in order to get put back onto hospice. And it can be more challenging and more burdensome for that patient if we do that. Understand the different paperwork involved with the hospice. With hospice patients, they're going to have a binder that's going to have all the contact information. It also should have all the patient's information in there as well. And it should have a DNR status. Those, with everyone that I've come in contact with, DNR status is on point. It is very well documented, but we still have to do a good job of making sure that the DNR is current and is filled out appropriately. These terminally ill patients may only need that supportive care from us, which might include assisting them with their prescribed, let's say, morphine for dealing with pain. And these patients typically are going to have the pill form of morphine. Some of them have the liquid form, which is you're going to find in the refrigerator. So it may just be a matter of assisting them and helping them take that medication as needed. And then ultimately, if there's any other questions or concerns with this hospice patient, you need to make sure that you contact medical control. Obviously, we'd contact the ER to find out what, say if we couldn't get a hold of hospice for whatever reason, contact medical control to find out what they would suggest. And when you do that, make sure you get the doc's name that you talk to. Ultimately, you want to follow our local protocols. The patient's wishes is kind of a big deal. Make sure you follow the patient's wishes. You want to follow all the legal documents and make sure that those documents are filled out appropriately. Ask to review the DNR and contact medical control ultimately if you have any questions or concerns. With these patients, you want to show compassion. These patients are in their final stages of life typically, and you want to show them compassion because this is a challenging time. Some of these patients are struggling not only physically, obviously, because they're terminally ill, but they could be struggling mentally in coping with this truly being their last stages of life. So you want to be compassionate with them as best that you can. Sometimes you're going to have to deal with these patients and they may be just difficult to talk to because of that mental anguish that they're going through coping with this. Again, try to be understanding and compassionate in dealing with these patients, and be very sensitive and be very patient, because truly death is imminent for them. Like this says, it's imminent. It could be that day, or it could be that week, it could be a couple months, but obviously with these patients, it's obviously imminent. Sometimes, let's see, maybe it's going to get into it. It can be challenging because it could be a chaotic scene. You could have family on scene as well that are not comfortable with what's going on. They don't agree with the current prognosis. So this scene may not necessarily be safe because of the chaos of family on scene. So making sure that we have law enforcement available to help us deal with some of that chaos. And, you know, we might have that patient who is all of a sudden they are in those final moments, and the patient's family is, again, not coping with this well and wants something done. There's another challenging moment when we still have to follow what the patient's desires were. They've got the DNR. They want to go off into the sunset on their own terms or whatever. And us going in there because the patient's family all of a sudden, no, you're going to do CPR, you're going to do this, you're going to do that. We need to try to do the best we can at managing that scene. Getting, obviously, your officers involved, and then law enforcement to help mitigate any chaos. All right. People who live in poverty. This is kind of the last section. So people who live in poverty are unable to provide for all their basic needs, including housing, food, childcare, health care, and medications. So for whatever reason, they're in a situation where they may not be able to afford good housing, or their housing may be in disarray. They may not be able to provide for themselves the food necessary to survive or to maintain a healthy lifestyle. They may not have the means necessary to provide quality child care or good child care. They may not be able to provide health insurance for themselves. So you're going to have these patients who maybe they don't want to go to the hospital. They don't want any treatments because they can't afford it. We have to be compassionate when it comes to these individuals and try to understand their care or their concerns. And with that, maybe try to find them alternate means of getting to, say, to a hospital instead of by ambulance. The catch with that is we still have to do a good assessment and then document appropriately. If this patient is adamant that they don't want to go by ambulance because they can't afford it, we better have that in documentation, because should something happen later on, that could obviously come back to bite us, because it's going to show as a patient refusal on our end, right? Medications, we might have those patients who can't afford the medications. I'm sure most of us understand that some of these medications are so outrageously expensive when it comes to like cancer and some of these specialty treatment medications, that you have patients who just cannot simply afford it, or they're tired of paying for those medications. So they may have other health issues, or their health issues are exacerbated because they're not staying up on their medications. So we have to have some type of compassion for their needs and their wishes, their lifestyle when it comes to this. As far as homeless, we don't have a huge homeless population in our area as it would be compared to, say, Spokane. But when we do come across those individuals who are homeless, we still need to show them compassion, treat them as anybody else that we would run on for 911, show them compassion, good treatment, good assessment, get them to that next appropriate level of care. You want to ultimately, here's the thing. So you want to be good advocates. You want to be the patient's advocate. You want to provide them quality care. You want to provide them that level of care that you would expect your own family member to receive. It doesn't matter what their situation is, whether it is disabled, elderly, homeless, crazy, cuckoo, cuckoo. Ultimately, you need to be that good patient advocate, provide them the appropriate care, provide them education. Sometimes that's all that really is required, is providing them education in receiving some type of care, whether it's psychiatric care or care at another facility. That's about all I got. Any questions? Online? I think you fell asleep on me. Did you? All right. Thanks, guys. That concludes 38. Rusty?